Assalamu alaikum warahmatullahi wabarakatuh. Welcome everybody, and this is a very special series of webinars regarding clinical research. As you know, as a clinician and trainee as well in the medical field, you should be able to read and also appraise clinical research. And if you want to go further, you have also to start thinking about doing research. Certainly, the road for starting clinical research can be challenging for many, but with the right approach, trying to get the basics right and trying to get the right mentor and start writing from scratch, it can be possible. Today, we'll be starting this series with a very prominent figure in research, Dr. Khaled Musallam, which I'm going to introduce in a few minutes. So briefly, we will be doing this session or webinar every Wednesday at 8 p.m. UAE time, 7 p.m. Saudi Arabia time, and we'll be discussing one aspect or topic every week for the next 5 weeks. The first webinar title is Study Design Essentials in a Nutshell. And today we'll try to address what are the different types of research and how can you design them, and you can have some basic understanding of these topics. At the end of the webinar series, we will be providing you with a PDF with some information and also some slides, and it will be available for you to download from the official Emirates Oncology Society website. I forgot to introduce myself, but this is Professor Humaid Al-Shamsi. I'm a consultant medical oncologist. I'm the director of VPS Oncology in the UAE, and also the chairman of the colorectal cancer in the Middle East, appointed by the NCCN guidelines in the US. And I'm also a professor at the University of Sharjah. This webinar series is sponsored and adopted by Barjeel Cancer Institute, the leading cancer research institute in the UAE. Barjeel Cancer Institute was #1 cancer research center in the UAE in 2021. I would like also to take this chance to highlight our recent publication, which is the Cancer in the Arab World. I was pleased to be the main person behind this idea, but certainly we had so many collaborators, co-editors, and also authors. After 5 years of hard work, this has been published recently. It will be available for free of charge in PDF format at Springer website in the next 1 or 2 days. I would like to invite everybody to download and have a look if you're interested in cancer, and also to share it with others. So there will be 5 sessions. This is the outline of the sessions every Wednesday. And we were thinking actually to combine session 4 and session 5 because the last session will be in Ramadan. So we'll be hopefully combining these two, and Dr. Khaled Musallam will tell you more about these last 2 sessions at the end of the webinar tonight. So Dr. Khaled Musallam, he has a MD and PhD degrees, and also he is the Group Chief Research Officer at VPS Healthcare. And I like to introduce people by their contribution to research. As you can see, Dr. Khaled Musallam high index is 52, which is a very high index. And this reflects his experience in clinical research. Dr. Khaled Musallam, he obtained his medical degree from AUB in Lebanon and his PhD from Leiden University Medical Center in Netherlands. He completed hematology oncology research fellowship at AUBMC and also at the University of Milan. He's a member of the Alpha Omega Alpha Honor Medical Society, and his globally renowned research portfolio. He collaborated with numerous investigators, including FDA registration trials, and he published in New England Journal of Medicine, Lancet, JAMA, Circulation, Blood, and many others as well. And he authored more than 180 articles, peer-reviewed articles. He's a frequent reviewer for over 30 medical journals, and he is ranked at one of the 0.1 scholars by the expert scale in 2019 and 2021, as well as among the 2% scholars worldwide for cardiovascular system, hematology, immunology, and clinical medicine in the recent Stanford University publication. Just a reminder, this webinar is managed by conveners, so thank you for their support. And I would like now to take Dr. Khaled Musallam, and before I hand Dr. Khaled, I would like to highlight something very important. This clinical research webinar is not about oncology only. You could be from any different discipline in medicine, and hopefully you'll be benefiting from this webinar. Dr. Khaled, back to you, and thank you for your support, Dr. Khaled.
Great, thank you, Prof. Humaid. Just confirming you can see my slides.
Yes.
Okay, perfect. Thank you, Prof. Humaid, for the introduction. Happy to be here with everyone, and thank you for all the attendees to make time to attend this. As Prof. Humaid mentioned, the main idea behind offering this series of I would call them webinars, but they're more tips and clues on how to pave your way through various aspects of clinical research is to give you something from my personal experience. Obviously, in research, there is a bit of theory, but it's mostly experience and things that you face in your own research journey. That's why I've been giving such a course for over 10 years now at various stages of my own career development, and it evolved with time. And I'm happy to share it with you in the next 4 to 5 weeks. I will reflect more on the whole program at the end to tell you what's coming next. But for today specifically, I thought we can start with one of the most important aspects of clinical research, which is study design itself, because study design is at the core of everything you do in a research study. It determines the protocol that you would go for to conduct the study, the type of analysis that you will handle or deal with to analyze your data, and even the type of publication you would go for eventually. And the concepts behind study design in clinical research are also very relevant to everything we will talk about in subsequent webinars, because I will keep referring to specific designs in specific analysis or specific aspects to clinical manuscript writing, for example. So to start with, there is no single way to divide clinical research studies in terms of design. If you take different books around clinical epidemiology or clinical research from the 80s and 90s and 2000, you'll probably see different terminologies and different ways of how things are split. But I'll try to share with you along the whole course what is most common. But there is no strict science when it comes to research. That's the whole point of research. It keeps evolving, and the methods even to conduct research keep evolving, and their terminology keeps evolving. The main two umbrellas under which the research studies come are always, probably you've heard of these two terms, are always going to be either observational or experimental or interventional. And what we mean by that essentially is that when in observational studies, you're not interfering in the natural course of care of the patient, whether it's in their diagnosis or in their management. So you're only watching the patients, whether you're watching them from now towards the future or you're watching them retrospectively in the past, you're not interfering in their course. However, in the experimental or interventional studies, you are introducing something new to this clinical course of the patient specifically for research purposes, and that could be something diagnostic or something therapeutic. That's why you also hear those two terms when we talk about experimental studies. And these are mainly things that you introduce for the sake of research to answer a research question. Now, mind you that the way we look at designs in terms of observational versus experimental doesn't necessarily mean that observational studies don't have actual physical intervention in them, because you might be just observing the patient, you're not interfering with their course of care, but you might need to prick them with a needle to take a blood sample, for example, for measurement of a certain laboratory assay. That might be in design. Scientific design is still an observational study, but when you come to regulatory approvals or consenting, you might still think of those interventional aspects of the study in terms of safety and ethics and compliance with GCP regulations. So under those two umbrellas, under the observational study design, what we will cover today is case report, case series, cross-sectional studies, and case control studies. And under experimental studies, we will mainly cover clinical trials. Now, the cohort study design, which is something that comes in between, as you see here on the figure, can be either or. So you can have observational cohort studies, and they can be retrospective or prospective, or they can be prospective cohort. When we talk about prospective cohorts that are experimental, that is what we actually refer to as a clinical trial. And all of these will make more sense now in a minute, because I will go over each individually to explain what do they mean. In terms of hierarchy of research designs, probably you've heard this many times from colleagues, from reviewers in journals, that clinical trials are the top of the pyramid in terms of quality, followed by prospective studies, then retrospective studies, etc., going down to a case report. And that might be true, and I agree with that when we're looking at an effect of therapy. The only way to understand if an intervention works, if a therapy, if a drug or a surgical approach works, is to conduct a clinical trial for it. But that might not be necessarily true when we're looking at etiology of disease or at evaluating risk factors or causal factors. It might be that the case report is at the top of the pyramid. It's the thing that started the whole understanding of a certain disease. Conducting clinical trials would be unethical, actually. You're not going to get two groups and let a group smoke and the another group not to smoke and then see if they develop lung cancer. So just keep that in mind, because there is always that immediate criticism if you're conducting a retrospective study or a study that is not a clinical trial because it's weak and it has limitations. That's true, it does have limitations, but sometimes it's the only design that you have to answer a specific research question. So it doesn't mean that it's low in quality per se. So what is the optimal study design? Many people ask me. There is none. It depends on many factors, and it depends on the aim of your study. What are the study questions that you are specifically trying to address? The feasibility, can you actually conduct a study in a certain design versus the other? And it also comes down to budget. To be realistic, some study designs can give you a better answer, but they come with a high build tag to them, and you will not be able to conduct them. So many factors come in play, and that's why we always say it's the study design that fits all of these things. It can fit the aim, it can answer the study question to a certain extent, it's feasible, and it's within the budget that you have available. When we talk about study aim, I usually try to classify those into four baskets. So what is the aim of a study? So you can always conduct a study for answering a question about etiology or a causation or causal factors. So for example, does HTLV1, which is a type of virus infection, cause lymphoma? That's an etiologic question, study aim. It can be about diagnosis. For the same, let's say, context here, can an assay detect HTLV1 infection in patients with lymphoma? It can be prognostic, so it's more of a prediction to see if your variable can predict an outcome in the future. So does HTLV1 infection predict early death, for example, in patients with lymphoma? Or it can be therapeutic. So does treating HTLV1 infection prolong survival, for example, in patients with lymphoma? Obviously, there are many various subcategorization or even deviations from those, but usually when we're thinking of study aim, these are the things that we look into. And now to go into the various study categories or study designs. And as I mentioned, the first one's in the observational basket, a case report. Case report is in fact a study design on its own, and it's usually a single patient description that's describing something unusual or interesting or educational even sometimes. So I will talk more about case reports in the context of how to write them and publications in the last session. But in terms of study design, usually case reports, we find them in most instances in those instances where you're probably referring to or trying to describe a case that was very challenging to diagnose, that is educational, for example, to the reader. Something that was reported for the first time as an adverse effect of a drug that was not seen in the main phase 3 clinical trials, or a new use of a drug that was used off-label, not approved for a certain indication by error or not even by chance. You found a benefit for it. So you have many examples in medicine where things started with a case report. Someone saw something in a case, reported it, and others took that information and converted it into a study. You can always have a single patient clinical trial and report it as a case report, for example, but these are obviously very, very rare. Sometimes they often come in as some very high-end intervention in terms of surgery or gene therapy. Sometimes the whole clinical trial is based on a case or two, for example. Case reports actually are still considered a robust source of evidence, especially in the instances that I mentioned. And you will find that regulators, actually like the FDA or EMA, they look for case reports in the literature after a drug is approved in the phase 4 phase of development, to see if there are any occurrences that others are publishing about the side effect of a drug. And they may lead actually to a full prescribing information or a label change with, for example, a box warning, just simply because a case report of a certain adverse event, a severe adverse event, was reported. Case series, as the name implies, just a collection of cases. Usually you see those in the literature when you're describing, for example, family studies for gene or genetic or rare diseases, certain rare occurrences you're finding at your center that you would like to put together in a report to share it with your colleagues, to tell them to describe those cases for them. They're usually either described individually, each case on its own, or sometimes you can put them in like a summary as a table. But the difference between case series and the other types of studies that I will go through is that you don't do much analysis in a case series. As soon as you start doing statistical analysis and reporting a group aggregate measures like means, medians, etc., you're looking more at a study here. And there isn't actually a universal number of cases to say this is a case series if it's 10 cases or less, for example, and if it's more, it's a study. There isn't. It can be still a study on 3 cases, as I mentioned. So this is just to give you a sense of these two types of basic but very important study designs. And then going into the various or the main 3 observational types of study designs. One thing that is common that you will see on all next and subsequent slides is that we're always looking at, and I'll go into this more in detail when we talk about analysis, we're always trying to get a sample from a population and perform a study on. And that has relevance when we talk about analysis and interpretation. I wouldn't go to it now. When you think of a case or of a study design, one common mistake, I wouldn't call it mistake necessarily, but maybe common trend or behavior is that you start immediately thinking of, is it in the past or is it in the future? Is it based on data that is in the charts, or is it data in the labs? To be honest, it doesn't matter. All study types can happen based on data that already exists or data that you will collect newly. All study types can be about future occurrences or past occurrences. The main thing that distinguishes them is that temporal, the time relationship between what we call exposure and outcome. Exposure is something like a risk, cigarette smoking, or a therapy, like anti-cancer therapy, for example. These are exposures, something you're introducing to the patient, whether really as an intervention or it's an environmental exposure, for example. Outcomes are any morbidity or mortality or any outcome, disease outcome or clinical outcome of interest that happens to the patient. So in a case-controlled study design, what characterizes this design is you always start with the outcome. So you go search for cases of heart attacks, for example, and you look back in time to see whether these patients were exposed to something, cigarette smoking for simplicity of an example. So whenever you start with an outcome and then go back to look for what was the patient exposed to, that's the case control study. And we call it case control because you try to actually compare, and we will talk about analysis in the next session, compare this exposure in patients who had the outcomes, which we call cases, compared to those who did not. So that's a typical case control study design. And just to give you an example of what I mean by past future exposure or available or new data collection. So you can do this study based on something that's already available in the charts, or you can actually start doing it on newcomers. So you wait until new patients come in with a heart attack to the hospital, and then you ask them, did you smoke in the last 20 years? Or you can actually go to your charts, 20-year-old charts, and look at patients, for example, in the year 1990, look at patients who had myocardial infarction, presented with myocardial infarction to your center, and then go back in the same charts back in time, see if those patients were smokers. So that's why the whole past and present and future doesn't necessarily dictate the design. It's all about the relationship between outcome and exposure. Now in a cohort study, exactly the same as I mentioned, but we go from a different angle. We start with the exposure. We start with cigarette smoking, and we look for 2 groups, for example, ones that smoked cigarettes and a group that did not. And then we follow them in time to see if they develop the outcome of myocardial infarction or not. Or we give them a drug A and a drug B to another group, and we follow them over time to see if their tumor shrunk. You probably have heard a lot with the terms retrospective and prospective cohort. The best way to think about this, again, is not to think about the chart. In reality, data is always in the past. Even if a patient came today and they did a lab study today, you're gonna take the reading from a lab report that already happened. Data is never in the future. Data is always in the past. What matters to say retrospective or prospective is that did this relationship between exposure and outcome already occur before you even decided to do the study? Then that's a retrospective cohort. Or are they happening after you actually decided to do the study? That's a prospective cohort. So I can go back in time and look into patients who were smokers in 1985 and follow them through the charts until the year 2010 and see how many developed myocardial infarction. Everything happened before I decided and started to do the actual study and looking at the data. In a prospective way, I will take patients who are smoking today and another group who are not smoking, and from today I start their follow-up to see if any of them will develop a myocardial infarction. Lastly, a cross-sectional study, which is probably the most simple form of a study design and the most common, and sometimes it is confused with others. It's everything else. So whenever you don't have a time element, you don't know the time element, or you don't care about the time element, or the exposure and outcome really happened at the same time. So I bring a group of patients to my study center. For example, measure something, measure their blood pressure, and at the same time, I make them fill a survey. And then I make an association or a correlation between the blood pressure and how they answered on a survey. I know that they happened at the same time. That's a cross-sectional study. Or I come into medical charts, they're in the past, and I actually look at patients' records to see in the year 1990, for example, I just take all the charts and I just see patients who has diabetes labeled as yes in those charts, and I see if they were smokers, also if it's a yes. And I make association studies between smoking and diabetes occurrence. In reality, I don't know who came first. Maybe those patients developed diabetes in the past and then they started smoking, or they started smoking, then developed diabetes. Nothing, they didn't look into time. You just looked if the patient has diabetes and is a smoker. You didn't ask the question, when did the diabetes occur or when? That's a cross-sectional study. Most people would mistake that for a retrospective cohort study. The best way to label this is a cross-sectional study based on medical chart review, if you want to keep that element of that you looked at the chart. But you're always going to look at the chart. Even if you do it today, you're going to have to go to the chart to get your data. So this is how they all look on a time scale. Again, as we said, just to summarize those, if you look at the cohort study at the top, you start with the exposure and you follow with time to wait to see for an outcome. You can do that in the future. So prospectively, you get patients that has the exposure today and you follow them now to see if the outcome develops, or you go to the chart and look at all of this happening in the past, a certain exposure in a certain year, and follow in time in the past to see if an outcome happened. Case control study, again, we said we start with the outcome that we have and we know today, and we go back to the case to look at the exposure. In a cross-sectional study, the exposure and outcome either happen at the same time or the time element is actually unknown. Most important thing is to know what are the pros and cons of each of those. So when should I pick this over that, or if I'm forced or I have to have a certain design over the other, what are the risks or the pros and cons or the risks and benefits? Cross-sectional studies are cheap usually. And I mentioned why they're cheap. Let's say all the cross-sectional case control and retro cohort, if they're mainly based on data from charts, case controls and retro cohort are usually the case. In cross-section, they could still be based on new analysis, but usually they're based on data from chart. That's why I'm mentioning here that they're cheap. While prospective cohorts, because you're measuring things newly, so you still need to recruit maybe some measures to be able to retrieve this data. It's not already readily available. Cross-sectional studies are fast. You analyze what you have. You don't have to wait for something to happen. In case control studies, we always say they're good for delayed outcomes. So if there is an outcome that takes years to happen, if I do a cohort study and I look at an exposure group today, I might need to wait 30 years, for example, until they have a stroke, because the rate of stroke in this disease is very rare. So I'd rather better look at patients who already have a stroke today and then maybe look back to see if they were exposed to that risk factor that I'm looking for. While cohort studies, they are good for rare exposures. So if there is something that's very rare, let's say asbestos exposure, you can't start with a case control study, look at patients with lung cancer and look in the past who got exposed to, because it's very rare. You're not going to find these in the chart. But if you go and identify those already that are exposed today to that, and then you follow them over time, it might be easier. It's just a matter of how you handle your data. Definitely the cons, mainly in cross-sectional studies, it's representativeness. Because usually selection is not based on exposures or outcomes. You just looked at the data at one point in time. The temporal relationship, as we said, are unknown, and they're vulnerable to all types of bias that I will talk about in a second in the other designs. In case control studies, we have something called selection bias. It can happen because you need to select controls, like we said. So you select your cases of myocardial infarction, and then you need to select patients who do not have myocardial infarction. Usually, there's a lot of selection bias there because it depends who did you select. Did you select the neighbors of those with the myocardial infarction, or did you go to the neighboring pulmonary department and got them from there, so they already have some sort of risk factor? So it creates certain bias. Also, if there were patients that were lost to follow-up over time in a center, so you decided to look at all myocardial infarctions today that you have in the center and look back at the exposure in the past, but maybe if someone had myocardial infarction 5 years ago and they left the center, you wouldn't even know if they're there, and they might be actually very sick and you didn't consider them. So that's another type of bias. Also, they have information bias because there is recall or missing data because you're relying on old data that happened in the past. There is always, if you go and ask patients, were you exposed to something 10 years ago, they might not remember. And there is always missing data because things might not be simply available in the records. Confounding is something we will go a lot into in the next session and the one after in interpretation, but it's also something that you worry about, similar to bias in studies. And usually here is incomplete information confounding. In cohort studies, in retrospective cohort studies, you don't have much selection bias because you started with the exposure and waited for the outcome, but you have information bias because, again, we said it's retrospective cohort, so you rely on data from the past. So it could be that some patients were lost to follow up, so you didn't find them as exposed, or there is recall or missing data bias. In prospective cohorts, obviously, you have much more control. You're more able to find the outcomes that you're looking for, the exposures that you're looking for, because everything is happening in the future. You're not at the mercy of the chart and what was available in them. So there's minimal information bias, and there is better accounting for confounders. And I'll go into these, as I said, when I talk more on confounding in general as a concept. Definitely the cons is cost, because if you want to measure now newly a certain lab for these patients, you need to pay for it because it's done for research purposes. And as we said earlier, it's unsuitable for delayed or rare outcomes because you would need to wait years probably. That's why you don't, those studies that look for the prospective cohort studies, for example, for exposures in infancy, looking at outcomes at age 40. These are one of the most cherished trials because literally physicians waited 30 years for outcomes to happen to be able to judge a certain exposure or risk factor. I'm going to give you just very quick examples. These are the references. When we share with you the slide later, you can look at them more commonly. Just not to lose the share screen, I will not need to open them for now. But just to explain to you what happened here, these are 4 examples of different types of cohort studies looking at the same actual question, which was, does air travel increase the risk of thrombosis? And there is these studies are actually the ones that coined the economy class syndrome. That's actually called by medical terminology, where prolonged air travel for 4 or more hours, for example, increases the risk of clots. That's why you always see on the planes ads or encouragement or awareness to move around in the plane or move your calves or so on. So the first attempt to look into that was a cross-sectional study, looking into a database to just see patients who had clots in a database under air travel exposure. And it was able, the study, to give some sort of indication about the association. But obviously the temporal trend wasn't clear. It wasn't clear if patients traveled for more than 4 hours, for example, 10 years ago, or was it last month. That's why it has some limitation of time. The next attempt was a few years after was to do a case control study. So another group in Netherlands, if I'm not mistaken, looked at thrombosis cases at a certain center, and they looked back in the records of patients. They merged their records to a national database of air travel from airlines, and they looked at exact exposure to air travel to see the case control design, whether air travel more than 4 hours actually leads to clot formation. Another group did it in a retrospective cohort style, where they actually looked at air travelers' history. They just looked back in time at records in one company, actually, employees of a company, and they looked at exposure to air travel, and they followed the charts of the records of these patients in the company to see if they made any insurance claims, for example, for thrombosis. They started from the air travel exposure and followed in time to see thrombotic events. The prospective cohort, this was also a study that took it to the extreme, but it actually did it prospectively. So a group of researchers went to an airport, it was Charles de Gaulle, if not mistaken, and they waited for patients to come down from a flight. And obviously, you don't have time to follow these patients in the future to see if they clotted. They relied on some markers of clotting. So they did actually ultrasound of the legs for patients coming down from long haul versus short haul flights, to see if the blood characteristics or the ultrasound characteristics in these patients were different. So you can see that you can actually address the same question in many different designs. The last study design we will go into is clinical trials, which is practically speaking a prospective cohort study, but it's experimental. So the exposure that I've been referring to until now is actually an exposure of an intervention, a drug, a therapy, a surgical intervention, a behavioral intervention, a nutritional intervention. Usually clinical trials are very governed, and there are so many things related to that. I will not go into the details, but most clinical trials today are registered before they start, before they initiate, on databases like clinicaltrials.gov. There are others in Europe, which was mainly a way to guarantee that clinical trials results are interpreted in a proper way, and whatever the trial shows is commensurate with what the trial actually intended to show, and not that you conduct a clinical trial and then you start looking at the data in the way that suits the results, the positivity better. That's why most clinical trials and many observation studies also are recommended to be registered. In most journals, they wouldn't even accept data from a clinical trial that was not registered on some of major database. You probably heard of these three common, let's say, labels of a clinical trial: randomized, double-blind, placebo-controlled trial. And I'll walk you through what each of these be, because these are the most essential things to understand about clinical trial. Randomization, obviously, if a doctor decides who will get an experimental treatment, there has to be some sort of random allocation that's not guaranteed. So you're not sure that the physician will actually unconsciously consciously give treatment for a patient over the other because they know something about their history. So I know that the patient is sick, I might actually give them a treatment over the other. So it eliminates conscious bias. This is also close to the concept of blinding, which I'll go to in a minute, but usually randomization guarantees this fairness at the start of the study. So the patient will take the drug at random, not because the physician decided this patient will take that drug. It also averages out unconscious bias, which is what we call confounding, that I will speak about in the third session. Because usually when we randomize, we expect that since I gave the different drugs, drug A, drug B, or drug A and placebo, to the two groups at random, if there are any differences in those groups, they're very minimal. The randomization, usually the main purpose of it is that you want to ensure that your two groups that you're testing are alike on average. They're similar. I randomly assign them. They can't be different. It's not correct. It's not possible. Obviously, it is, as I write down here in the disadvantages, but that's the main reason. So that the only difference between the two groups is the exposure. Group 1 takes a drug, group 2 takes a placebo, for example. Obviously, the disadvantages in randomization, usually sometimes it's ethical issues. This is a long list of things about, is it fair to randomize patients to things and not give them a certain drug based on their condition. Sometimes it interferes with the patient-physician relationship because patients come to you as physicians expecting you to give them a drug for their treatment. But if you say, I'm going to give you something at random, it gives a different connotation to that. There is administrative complexity to ensure it's done properly. And as I said, a like on average is not guaranteed. So we randomize. So technically speaking, you expect for the most common or known things, the two groups are going to be balanced in terms of age, gender. But there are so many things in genomics that could still be there. There's always random variation. Randomization method, there are many. There is the simple randomization, block randomization, stratified randomization. You don't need to worry about those. Usually whoever is sponsoring the trial has a reason to select one over the other. Probably the stratified one is most common, and it's done in a way to guarantee that you have a certain number of patients based on certain grouping that you're interested in. So you're conducting a clinical trial, and you really want to make sure that there is enough people, patients in it from Asia, Middle East compared to US, Europe. Because if you leave it to just a chance, it might be that there is much faster recruitment in the US, and you have 90% of the trial is from the US and Europe, and only 10% of in the Middle East. If you want to guarantee a certain number from each continent, you do stratified randomization. The way you randomize it is very technical. So in the past, it was just investigator performs the randomization. I try to do that randomly. Obviously, that's the worst type. And then the methods evolved, and we have many systems now, voice response systems, web-based systems, that usually the clinical research organization supporting you with the trial will support with this, where you, for example, go to the website and you get a code for the next patient coming in. Based on the code, you pick a vial, and so on. Or it's something that you call a phone number, and then an automated program tells you which next patient to give them vial A or vial B, for example. Blinding can be single blind, double blind, or triple blind. When we say single blind, we mean only the patient is blinded. When we say double blind, we mean the investigator and the patient are blinded. Triple blind, also the statistician. And what does blinding do? It does decrease the chance of post-randomization differences, because even if I gave the patient, I assigned the treatment and placebo, for example, at random. But then if I know that this patient is on placebo, I didn't decide, randomization put them on placebo, maybe I'll start treating them different as a physician. I'll give them more care because I know they're not getting the drug. I will give them more vitamins, more supplements. I'll ask them not to do something. Or the patient, if they know, they might start behaving differently if they're on a placebo. If they're on a treatment, maybe they will start ignoring certain things. If they're on placebo, they'll be worried that they start doing things more commonly. So that's the main point of blinding, so that these things don't happen during a trial. Last thing is, why do we have a control? Why do we choose to have two arms in a study that you randomize to? The first thing is to remove subjective effects, because we know, I'm sure it's something you've heard of, it's called the placebo effect. Because sometimes, especially if you have some maybe behavioral or psychiatric or pain-related, sometimes blood pressure-related, many actual conditions, you see a very strong actual placebo effect. That you see patients improve just simply because they're taking a pill, even if this pill doesn't have the active or chemical ingredient. And that is what we call the placebo effect. So you need to control two arms so that you can actually subtract that effect from the effect you see in your treatment arm, and you get the true effect of the drug, and remove the part that was just because the patient is taking any type of pill. There are also obviously objective effects. You want to see them in different groups, like circadian rhythm. That's why sometimes you need to see things happening in both groups, so that if there are changes just because simply you're measuring the blood pressure at night compared to the morning in one group versus the other, you see that difference. And we have something that is a bit complex to explain. It's called a regression to the mean. There are many physiologic things in the body that usually, even if they're bad at a certain time, they might go back to normal on their own, like infection, for example. Many times, that's why there's always a regression to the mean bias in antibiotic studies, because you don't know if the antibiotic worked or the infection subsided on its own, because simply the body was able to naturally get rid of it. And this slide is actually explaining the different, let's say, types of clinical trials, as usually are called or labeled in pharmaceutical industry, based on some more logistic aspect, not necessarily only design elements. So you heard about probably phase 0, phase 1, phase 2, phase 3, phase 4. Again, there is no solid science here, but usually the phase 0 is one of those earlier trials in a program that's developing a drug in a certain pharmaceuticals, where the main focus is about PK and dosing and some sort of safety, but it's mostly on PK and dosing. Then you move to a phase 1 trial where the focus becomes also equally safety. You want to make sure that the drug is safe. These usually are done on healthy volunteers. Sometimes they are done on patients if the drug is approved for another indication, for example. And then you move to your phase 2, where you start looking at elements of efficacy to see a signal of effect, not only safety. And then you confirm these findings of safety and efficacy in the phase 3, which is usually what you use to register the drug with the regulatory agencies. And this is usually the one that is randomized, double-blind, placebo-controlled. Mind you that even phase 2 and phase 1 can be randomized, placebo-controlled. We have also precedents of certain registrations of drugs were based on phase 2 trials. So it's, again, as I said, it's not something solid, but I'm sharing with you what's usually more common. And usually what we refer to as the phase 4 program, it's usually more than one trial. And obviously the phase 3 can be more than one trial for a certain product. In phase 4, you usually focus on safety, usually also efficacy, but mostly safety, to make sure that you capture long-term effects of therapy that you may not have seen in a one-year phase 3 trial, for example. And usually these are, we call them post-marketing commitments or requirements from the regulatory agencies after you register the product. So you'll be granted licensure for selling the product, but then you still need to conduct those studies to make sure everything is in order when it comes to safety. But the last thing I wanted to include here is a design. Also, it's a study which is called a meta-analysis. Probably you've heard of that. I'd go into systematic reviews, etc., in later courses that go into write-up of these. The meta-analysis are usually pooled. It's a pooled analysis. It's not a study on its own per se. You're actually taking data from multiple observational clinical trials, taking the raw data back and reanalyzing it as one big study. So obviously that immediately gives you a sense that it's going to be a more powerful outcome, because instead of getting data from a clinical trial of 300 patients, you took 10 trials with 300 and you have data now from 3,000 patients. And it has a very sophisticated methodology of how you would do these. And the reason we do them is that in many instances, we do see a lot of conflicting data from different trials. That's why you need to pull them together to see what is the collective conclusion from all of these trials. There are many entities and agencies, like the Cochrane database, for example, that conduct these regularly for certain research questions, and they keep updating them to ensure that the most recent, let's say, conclusions are there. There are still choices that investigators make here, which can introduce some bias as well. How to search for those trials or studies, which ones to select based on what criteria to include, because sometimes they don't include all trials. They have to have certain criteria to include them in the analysis. How do you deal with incomplete data? Which methods to use to analysis? And how do you address the actual original biases in the study? So all of that feeds into some sort of interaction between various investigators to conduct this as a type of study, more or less. With that, this session comes to an end. Just to give you a hint of what will be coming next. So hopefully, please watch out for the registration links and adverts, especially by Professor Humaid for the next session, because we might change the timings, especially for the last two. We might combine them just for Ramadan. But essentially, irrespective of that, what we will go over next is the next session, which will be a bit longer than this one, more technical. We will go into statistical analysis. Obviously, no one can be a statistician in an hour and a half. You will always need a statistician on board in most studies you conduct, but this might make it easy to speak to biostatistician if you understand what test you're actually looking for, or if you have a simple analysis or analysis on a database in your hand, you might actually find this session your results? How do you? Sorry, I think it was muted by mistake. Can you still hear me, Humaid?
For a minute, for 20 seconds, we didn't hear you, but
Okay. Yeah, I was just referring to the second session that it will go over the research questions that you can find and how to analyze those alone. But most likely, this is to empower you to be able to speak to a statistician and ask for those. And then we will go into do's and don'ts in results interpretation so that you will understand after you find these results or you get them in a statistical analysis report from a certain biostatistical company or a colleague, what do those mean? What does the confidence interval mean? P-value, what do they mean? And then the last two sessions will go more into how do you actually write the data, how do you put together everything into a publication. So obviously I welcome you to attend all of these, but just in case any of these are more important to you than others, I just wanted you to understand what will be covered. I'm gonna check if there are any questions on the platform to address those quickly. So there is a question about difference between nested case control studies and case control studies. That's a very good question. So nested case control studies is a case control study that you take from a cohort. So you have a cohort design. For example, we've recently, not recently actually, it's 10 years ago, but time flies, looked into a very large database from the subsurgical database in the US, and all the data was collected in a more cohort fashion. So you have exposures prior to surgery, and then intraoperative findings, and then outcomes after surgery. But for certain analysis, what we did is we had to look at cases within that cohort, the outcomes themselves, and then go back and look at the exposure. So it's more of a, taking or looking at the data from a case control perspective through a design that collected data in a cohort study per se. Yeah, I think that was the main question that we have. Great, I think there were some hands raised. We still have 10 minutes, so I don't know if for the audience who have the hand raised, if you have any question, more than happy to answer that. Otherwise, you can keep it for next time or get in touch by email. I'm always happy to answer any questions, or just find me on LinkedIn. I'm happy to answer any key questions.
Actually, there is a question from Fatma Al-Kindi. She's asking, do you recommend publishing case report as a letter to the editor? I think the answer would be depends on the journal.
Exactly. I will go into that in the last or the combined last session. I love letters to the editor because they're usually very flexible in terms of their structure. Usually there's limitation in the number of words. And you find that the case report section in most journals is not there anymore. You have obviously some new journals that are coming and very specific to case reports or still have case reports. But if you intend to go to a higher impact factor journal, most of them don't take case reports anymore. And the only way to actually put it is to transform it into a letter. So it's just a matter of choice and luck with the journal. But I see no reason why not to publish it as that.
Professor Khaled, I would like also to highlight something very important, and it's for most people who are interested in research. The first step to do clinical research is to get your basic knowledge and also to get a mentor. Not any mentor, a mentor who publishes articles. If you get a mentor who doesn't have, experience publication, unlikely that you'll be able to publish anything. So try to find someone who is willing to mentor you, and also try to get someone who publishes at the same time. If you get someone who publishes and who is interested to mentor you, in no time you'll be able to learn some of the basics. And trust me, the first few months or years, they're difficult, but after some time, you will enjoy doing research. You will enjoy bringing your own questions, own ideas, and then making these things happen. There are other few questions, maybe Dr. Khaled, if you want to.
Yeah, I don't know, they're a bit squeezed on my screen, so if you can read them. You see them also, Humaid? Let me just try to pull through. So there's a question about the slides. We will make those available. As Prof. Humaid said, he will post, I will prepare them like a package so it's easier for you to follow, and we will make it available as a PDF on the EOS website by the end of the month when we finish, so that you have these all together. Yeah, I can see the questions now. So nested code, we answered that. Which is the most published study design in the literature? Good question. We can check that on PubMed, but I would say there's plenty of observational studies out there. There's definitely more observational studies than clinical trials, but definitely the most published is translational basic science. There's much more scientists in the basic science world than us clinicians. But in terms of between the clinical study designs, I wouldn't say there is a lot of, obviously, for ease and cost issues. You will find probably more chart-based retrospective observational studies than you would find prospective data collection, etc. So it just goes with the difficulty of data collection. A question to re-explain the difference between cross-sectional and cohort studies. And I said the main, if you want to not complicate it, just think of, as I said, the exposure and outcome. It's all about you as a researcher. What did you go look at first as your main data source? If you looked at the cases, cases of thrombosis, let's say, and then looked back in time to see if there was an exposure to a certain oral contraceptive use, for example. These are usually the most common examples how these data came up. That's the case control. You started with the cases, thrombosis, no thrombosis, or patients with cancer, patients without cancer, and look back in the last 10 years how much they were exposed to antibiotics, for example. Now there is a lot of data coming up on antibiotics use and the risk of cancer, for example. In a cohort study, you will start in the opposite way. You will go and find a group of patients having or taking antibiotics, another group that is not taking antibiotics, and wait in time until they develop cancer or not, and then do your analysis. And that can be something that already happened. You're just looking back at the literature to find it, or something that is coming in the future. So you started now looking and observing.
There is a question
meta-analysis
regarding resources, and I'm going to post this name of the book. The User Guide to Medical Literature is actually a book written by Dr. Goran Rangait, our professor from McMaster University. He's the father of evidence-based medicine. And this book actually is a great book. I'm going to post this name now to everybody. You can find this book online. And actually, it explains to you everything from A to Z, and it's a great, basic that you can explore as a reference.
Excellent. And when we share also the PDFs, I will also put some sort of references at the end of each session as well. How do imaging insights play a role into your clinical research questions? Not sure I got that, but I'm assuming that the use of radiologic data, they're just another study variables that you can look at as an exposure or outcome. How the sample size calculation, we'll talk about it in another session. Recommendation for further reading, as Dr. Humaid mentioned one, and we will also post some other references.
Dr. Hassan Ghazal, we are seeing a lot of applications, a lot of them are poorly designed and just published with really no impacts, meaning it just increased someone's CV only to comments. I think, Dr. Hassan Ghazal, there is no research that's not useful. In fact, I do believe that if you do research, you will not be able to publish these unless you have a good understanding of the topic, and also you formalize a question, and whatever you learn as a researcher from this, you will be able to implement this into your clinical practice. So I don't see there is a bad. Certainly, there's some bad research, but certainly, if you have a good research that you publish it, maybe sometimes you don't have like high citations, but certainly one day someone will use it. I'll give you an example. The first paper about controlling cancer care during during pandemic was published in 2006. by a Canadian physician. Citation was 0 at that time, and nobody really cared about it because only the publication. Now it has more than 100 citation after COVID because it was the only paper. So certainly maybe some stuff doesn't seem valuable for some, but certainly for others it can be valuable, especially for the researcher who's doing the research.
No, I totally agree. Obviously, there's so many elements to why people engage in research. The number one factor is to get promoted in a university, and but that's fine as long as sometimes the motives of research matter less than the actual content. So obviously, if the content is valid, has a certain learning and understanding, the good thing today is that in the majority of cases, research is controlled. There is peer review process by journals, and the journals have a system that we will talk about later and metrics that you will be able to, as a reader, put everything together and make your own assessment and judgment about research. Because at the end of the day, it's your personal view about the research. I might read a clinical trial in the New England Journal of Medicine and I don't agree with it, and I think it's not done properly. While maybe a study in a local journal that simply the authors didn't have the chance to publish it in somewhere more prestigious might be more valuable to me. Definitely, it's personal. There is definitely a commercial aspect. I'll also even go into that. Journals are still also publishers, they're businesses like book producers, book publishers. So there are still commercial interests in that, but that's the case with everything. Even the textbooks we studied from in medicine were sold to us, at least where I studied. We had to buy them and pay for them. So there is definitely always a commercial aspect to evidence per se, but hopefully the more we engage, the higher the chance that you will find something more qualitative, that's for sure. I'm not sure if I missed any questions. Sorry if I did that because they were a bit jammed a little bit on my screen. But if you have a critical question that wasn't answered, I invite you to connect with me or Professor Humaid and send that question. More than happy to answer that. Just being aware of the time for people, I think we have to wrap up and hopefully just stay tuned for next session's announcement, which hopefully will be same time next week, unless there is any burning reason not to conduct it at that time. I'll come prepared with lots of coffee because there will be a lot of statistical analysis, but it will be a good. It will put you to sleep immediately after, I promise. But you will gain something from it, that's for sure.
So Khaled, usually doctors don't like math, including me, but we will manage. We'll manage.
I try to make it as simple as possible, and actually, when you get the slide, there are just tables. If you math, as you said, math is not for everyone, but I found it very helpful to understand the formulas behind things, so that you understand why am I looking at this? Why is it reported as a hazard ratio, not an odds ratio? So I'll try to cover the most, let's say, important things relevant to interpretation, but it's inevitable. You want to talk statistics, you have to go into a little bit of math, at least the basics of means, medians, and samples, and so on.
Yeah, and again, this will help you when you talk with doctors, when you're trying to read some articles to understand the significance, when you try to talk with the statistician. All these aspects will be important. So thank you so much, Dr. Khaled. I know you had cold, not COVID today, and you were not feeling well. And thank you so much for keeping the session on time. We appreciate your time, expertise, and we look forward to see everybody, inshallah, next Wednesday, 8 p.m. UAE time. So thank you, and we look forward to see you all, inshallah. And also, we'd like to hear from you feedbacks through our groups and also through the email. Thank you so much, and have a good night. Dr. Khaled, back to you.
Thank you, everyone. Thank you for the time, and I hope you found this useful, and happy to see. If you really found this useful, please come for the next one, because it's a story. If you attend all of the webinars, you will definitely benefit more than attending a few or one of those. So good night, everyone, and hopefully we'll see you next week. Thank you.
Assalamu alaikum.
Bye-bye.